Good evening, everyone. Here Imran Abbas. We are live. Again, I am live. I am live from Dubai. And Professor Karl Miller, he's a legendary bariatric surgeon, one of the well-known bariatric surgeons at the globe. And as all you know, the role of Professor Karl Miller, especially for promotion of bariatric surgery. It is really great honor to interview such a great surgeon. Sir, so much thanks and for acceptance our invitation. Sir, over to you.
Yeah, thank you, Professor Imran. It's absolutely a pleasure from my side to attend and to speak about Runway gastric bypass, because that is the majority of my procedures. So therefore, I'm really very enthusiastic on that, and I'm looking forward to your questions. I will answer spontaneously. Honestly, I'm not prepared to that. I really give you absolutely on-demand responses, and that as really honest.
Sir, so much thanks. As you know, we have some repeated question, and this series of Runway gastric bypass, we have started with Professor Himpan, and we will continue this interview series till June 2022, and June 2022 we will have a sum up session. Sir, because we have some repeated question, personally I know yourself, but our youngsters also are interested to know more about you. So, sir, your brief introduction, your journey of bariatric surgery, and especially journey of Runway gastric bypass.
It will be my pleasure, because the history, how I came to bariatric surgery was really very unique, was very strange. So my name, Karl Miller, you mentioned, I'm professor of surgery, and it was in 1992 where I attended one of the first world congresses on laparoscopy, where I presented my first 2 small bowel resections laparoscopically. I met one member from a company who wanted to show me the angle-shake prosthesis. That's a device at that time in the 90s to treat reflux. And I did laparoscopic anti-reflux surgery in 1992, which was, let's say, one of the pioneers, together Delamange and Professor Rudolf Pointner, etc. So based on that, I invited this company to my university hospital in Salzburg. But at that time, angle-shake was removed from the market. So this guy showed me the gastric band, and that gastric band from Bariatric at that time. And I said, well, that's really interesting, but this is something to treat obesity. But to treat obesity at that time, I understood this is a multifactorial disease. It's not just to treat the weight. And I looked for an expert, a specialist on that. And I met very close to Salzburg, Professor Emmanuel Hell. He was very well known at that time to treat small bowel resections, so ileal bypasses, VBGs, vertical banded gastroplasty. That was his specialty in open surgery. So I met him and I said, what if we meet together? I do laparoscopic procedures and you invite me to your hospital. So that was the beginning in 1992, first laparoscopic gastric bandings. And then we spoke that we need a team at that time. So we looked for a psychologist who was interested in treating obese patients, a nutritionist. So that is from that time, the very first multidisciplinary team built in 1994. Nowadays, I have 3 psychologists in my team and 2 nutritionists that work closely with me. Although I'm meanwhile not anymore this high volume surgeon that there was a long time previously. So that was the beginning. And for sure, you will ask, when did I start gastric bypass? Because as mentioned, 1992, I started the bandings. Then I visited I think anyway, it was 98, one of the world congresses, and it was Professor Whitgrove. Alan Whitgrove spoke about his first laparoscopic gastric bypass. And he took around 10 or 11 hours for his first. He said, never ever I will do gastric bypass procedures. 1 year later, I visited Jack Himpens. You mentioned already this really master in laparoscopic surgery, and he showed a technique which was really a good possibility to adopt. Then I visited also Guy Bernard Cadier, and of course, especially the Swedish Torsten, and it was amazing to see laparoscopic gastric bypass is feasible. And when you see extremely obese patients, you realize that adjustable gastric banding will not fit properly in those patients, and so on. So it was in 2000 my first laparoscopic gastric bypass, and from that on it became the mainstay of my procedure. That's a little bit the history.
Sir, excellent, sir. Sir, really, it's a great honor. Today, I am talking with someone who has experience of bariatric surgery about 3 decades. And also, definite, when this is, in my opinion, great opportunity for my viewers and especially myself, because first, personally, I learned a lot, and definite tonight, it will be one of the best session. Sir, so definitely we have some repeated questions, and then we will talk about this. And also we will take some questions from our viewers. Overall, we divided our question in 3 parts. So some pre-op or patient selection, then some technical, and at the end, so about post-op and follow-up. Sir, according to now, more than 2 decades, because we have started Runway gastric bypass in 1998. So definite. So this was, then you start, and I know, so evolution and everything, we will talk about this. But now in 2022, according to your experience, so what is your protocol, and about patient selection? So this is about the selection. I want to know about your side. That is a relative and absolute contraindication of Runway gastric bypass.
Well, let's talk about contraindication, especially when you have patients with a family history of carcinoma. When you have this kind of history, I would say a Runway gastric bypass is not, let's say, the best option on the first side. But in principle, the patient has to live the rest of his life with the procedure that you perform. So basically, when you think about a non-reversible procedure, this is what the patient has to understand. Even let's say gastric sleeve gastrectomy or sleeve gastrectomy is slightly less risky. It is non-reversible, and we have quite several number of patients who are not very confident and happy with this kind of resection procedure. I met in the beginning of 2000 Edward Mason. He's the inventor of the gastric bypass. I had personal contact with him. And God bless his soul, he passed away during the pandemic, but he's a very wise man, and he told me that during all those decades, from the beginning of the 50s last century, there were around 50 different kinds of gastric bypass developed. So the best idea was always to learn from experts like Jacques Kimpens, Pierre Cardin, and the Swedish. I lost his name, but it's absolutely necessary to learn from experts and get their experience. So regarding contraindication, first I ask my patients, what's the expectation? A real contraindication for a Runway gastric bypass is a very, very, very obese patient, where you say the procedure is on a high risk. The patient has other diseases that put him itself additionally on a risk. So that is for me definitely a contraindication, where I consider more a two-step procedure, where I say for those very, very sick, super heavy obese patients that we call super obese patients, those will most probably have a two-step procedure where you do a gastric sleeve resection and then a duodenal switch procedure. But that is another topic at another time. So basically, the indication is much better when you first listen to the patient's history, about family history, about what his, let's say, idea why he got this heavy weight and this disease, obesity, and a lot of other questions like sleep, stress, medication, etc. So the entire history. And then I would like to hear from the patient what he already considered as a procedure. I do more ask questions than to, let's say, select. I basically guide and lead a conversation by asking questions.
Sir, excellent. Sir, because you have excellent experience in Middle East and also in Europe. So in Middle East, so when you are practicing here, definitely you deal different ethnicities. So at that time, this is my opinion, maybe I am wrong. So when you are working in the same type of people and dietary habits, like if you are working in Austria, so maybe more than 90% you are dealing with the same type of people. But when you are practicing in Dubai, so definitely maybe every next patient will be from a different culture, different ethnicities. So in such a situation, so how you guide, how we must select, because one of the most important, which patient is not good candidate for this surgery. Yes, we have the list indication. So which one is not good for sleeve, which one is not good for OAGB, which one is not good for Runway gastric bypass? Because now we are talking about like smokers, like someone who is suffering with so liver disease or so like cirrhosis, Crohn disease are different. So because according to your experience, we are interested to hear from your side, especially smokers, someone.
Basically, I'm accepting smokers, but I have to explain those patients that usually you have at least 6 to 8 weeks preparation time for a surgery. So now you understand that in Middle East, in Dubai, I operate very rarely patients because you spoke about ethnicity. Those patients, they expect immediate surgery, and that is what I don't do. So in Middle East here, in Dubai, I mainly do redo surgeries. So those patients who have really severe problems with already having had surgery, and patients who really want to have Runway gastric bypass. Because there are so many surgeons doing very, very excellent sleeve resections, so I do not need to compete with those surgeons. I do not do mini gastric bypass routinely, only in very, very selected cases. My classic let's say, expertise is in the Runway gastric bypass. So therefore, I have patients who already look for those kind of surgeons, and I have patients that need some conversion surgeries. So that is practically my work here. In Austria, we are much more open to Runway gastric bypass. If you look on the IFSO statistics, we do have really a high number or a high percentage of our patients with a Runway gastric bypass, or at least with a, so to say, one anastomosis gastric bypass. That is basically my work here.
Sir, excellent. Sir, regarding, so because in your main practice, so this is really interesting for myself. So you have started, according to, so as you have mentioned, after gastric bending, so you have started Runway gastric bypass, because most of our surgeons, they start gastric bending, then sleeve, then gastric bypass. But you are one of the pioneer of gastric bypass at the globe until this time. So still your main practice, this is really interesting. And because due to this, in my opinion, tonight will be one of the best session. Sir, according to your experience, have you any age limitation for adolescents or older age? Because when age is more than 60, 70, so they cannot tolerate hypoabsorptive procedures or malabsorptive. So what is your opinion about age?
Yeah, so age doesn't really, is not really a criteria. I have a contract with the university clinic still in Salzburg treating adolescents. So the age starts from 14 up, only Runway gastric bypass. So those are highly selected patients with really enormous weight, with, in, let's say, a preparation time for almost 1 year with the multidisciplinary team. So usually bypass I start with the age 14 up. My oldest patient was 74 to my knowledge, and he reached the age of 86, passed away unfortunately with pancreatic cancer. But I cannot tell you how his life changed after this procedure. He visited me regularly to the follow-up clinic, and you see the change of a patient who barely could move to someone where his wife told me she's a little bit scared, maybe he will get a girlfriend now. So age, I had a couple of patients that are over 70 with a BMI, body mass index over 40, but mainly with big bellies. So very thin legs, big bellies, diabetic, hypertension still, and of course it's a higher risk, but those patients are very, very well informed and also very well prepared to that kind of procedure. And I also have to admit, thanks to the development of technology, we do have now much better instruments available compared to that we had in the year 2000. Much better camera, better view, insufflation that is preheated. We have smoke evacuation. We have stapling devices, energy devices, and antibacterial coated sutures available. So we have really barbed sutures that make your life much easier. And meanwhile, you do Runway gastric bypass with a routine team less than 1 hour. So it's absolutely, let's say, from my side, a great development in the procedure compared to last century.
Sir, excellent. Sir, according to your practice, your protocol about pre-op endoscopy and H. pylori eradication.
I mentioned already that I have usually 6 to 8 weeks preparation time. That means the patient, first of all, a psychologist, to be aware what will happen in the change of his life. Meanwhile, he gets also a consultation for gastroscopy, and so endoscopy, Helicobacter pylori eradication in case it is positive. Then the patient has to consult a dietologist to know exactly about this vitamin deficiencies, about the supplementation. And I never, ever take a schedule for a surgery on the first appointment of visit. Never, ever. So a patient really needs to have time to realize what will change in his life. You mentioned already malabsorption. That usually doesn't happen with the classic Runway gastric bypass. It is that you get, let's say, deficiency of some minerals, vitamins, yes, but a malabsorption per se, per definition, is not happening with the classic Runway proximal gastric bypass. But the limitation, of course, is also the weight. It doesn't make sense if you have body mass index over 50 and the patient expects to get less than 30 BMI, is non-realistic with a proximal Runway gastric bypass. So there are really multifactorial criteria that you have to consider then.
Sir, excellent. Sir, now we will talk about some technical points. And now about more than 2 decades, you are practicing Runway gastric bypass and your main practice indefinite. During this period, you evaluate your technique. So we are really interested to hear from Professor Karl Miller in 2022. What is the standard technique of Professor Karl Miller? So the size of gastric pouch, size of gastrojejunostomy, and so which stapler you are using. We are interested to hear from your side, sir.
Okay, from the technical point of view, I always started with the anterior anastomosis. That is usually the part or the part of the procedure where you have a way out, where you can go back if in case patients develops during surgery any problem with the anesthesiologist, or the mesentery is so short that you cannot really lift up properly your let's say small bowels. I always start with the anterior anastomosis. It's the most relaxing part from my side, and it's done in 10-15 minutes at least. You have your first anastomosis. Regarding the pouch, is really standardized since the first days of 5 to 6 centimeters from the esophagogastric junction on the lesser curvature. So I dissect a very small entrance to get to the retrogastric space. And usually you have above of this entrance a very nice vessel that deploys blood and perfusion to your pouch. I transect horizontal around 5 centimeters, and then I go to the angle of his. So the pouch usually is very small. It maybe has 15-20 cc of volume. Before I moved to Dubai, I used always circular stapled anastomosis. But then I realized that financial pressure in some hospitals lead me that I had to do the anastomosis linear, and there was practically from the outcome no difference. The size of the anastomosis is exactly 4 centimeters, and that measurement you have on your stapler. So that is practically an end to side gastrojejunostomy. And then I divide the loop in between the anterior anastomosis and the gastrojejunostomy. So that's basically my technique. I close all the mesentery defect that I can close. That's usually the defect in between the biliary limb and the alimentary limb. And then, of course, the so to say Peterson space, the defect in between the mesocolon and the alimentary meso.
Sir, so much thanks. Sir, one of the issue that maybe I don't think in a coming decade also we can solve is BP limb. Because due to different ethnicities, different culture, dietary habits, so we cannot standardize this BP limb. But overall, we are interested to hear from your side. So what is your criteria when a patient, BMI of patient, age of patient, comorbidities? So when a patient with BMI 50, age 50, diabetic, so and a male patient in Austria, how you will deal? And same patient that is so vegetarian in Dubai and use less carbs, how you deal with such a patient?
Basically, if it's possible, I do the routine 50 centimeter biliary limb and 100 centimeter alimentary limb. That is usually the routine patient. But then you have patients that are, let's say, severe diabetic, where I put the biliary limb longer, where I made the biliary limb longer. And the higher the BMI, maybe the biliary limb is sometimes 1 meter or 1 meter 50, but the alimentary limb, when it comes to that part where I perform a longer biliary limb, I measure the entire small bowel, not to get a short common limb.
So, sir, when you prefer longer BP limb? In initial, we are talking about initial surgery.
Yeah, if the patient is older, has more metabolic comorbidities, dyslipidemia, diabetes type 2, hypertension, and then also where you say, I want to achieve more weight loss, but that is practically what I got from colleagues, where they say, how do you do? What's your experience? The studies are not very sufficient on that. It's more an experience. But in a routine surgery, patients with 50, 100 don't have really significant problems like dumping syndromes also.
Sir, excellent. So when you measure whole bowel length, so again, what is your standard? That is 30, 70, or how much you bypass, or how much will be your BP limb at that time? Have you any?
Okay. No, the minimum that you need for a common limb that the patients will not really probably have problems is 2 meter. So 200 centimeter. And I have measurements on my grasper so that I can really precisely measure the length. So in that case, I decide a longer biliary limb in those who have a higher BMI and those who have more metabolic problematic.
So then the most important thing in such a cases is common channel for you. How much you safe common channel, that is the most important. Then you will go ahead. Sir, yeah, please.
No, I even saw it in duodenal switch procedures when the common channel is 2 meter. At the beginning, patients lose enormous weight, but I still have patients that gain again weight even with 200 centimeters. So you see the disease of morbid obesity is simply extremely difficult to treat. And from my side, I do not want to overtreat. So I do not want to harm patients just for the sake of weight loss.
Sir, personally, I have not this experience, just asking from your side. One of the concern when we do long BP limb is so definite malnutrition, because our proximal jejunum or jejunum part is important. When we bypass complete jejunum, there is more chance of malnutrition. This is our main concern. So what is my question? If we do standard Runway that you are doing, okay, just 50, 100. And then in the same session, you do distalization like sugar man. So just cut that limb and distalize this. So what will happen? in your so elementary channel, we have jejunum. Jejunum is there. So in your BP limb now, ileum is in your BP limb. Not you have not completely bypassed your jejunum. Okay, you are using your jejunum. You are still your jejunum is in the loop for. How you think about this? So maybe then I have no experience. Maybe we will bypass. We will achieve that weight loss, but maybe less malnutrition.
You raise a really very interesting topic, and then and that's the topic of conversion. Distalization, I did, yes, but what I do not recommend, just by talking to my colleagues, and especially the Spanish group is very experienced on that, I would not do a longer biliopancreatic limb than 1.5 meter. Regardless how long the common channel is, because what we know from the studies in France when it comes to one anastomosis gastric bypass, that those patients who have 2 meter biliary limb or even longer, they have more problems, they have more side effects, they have more complications, and that is really proven by a randomized study. So if you talk to Chevalier, for instance, he would recommend, and he's doing really thousands of those procedures, biliary limb maximum 1.5 meter.
Sir, I agree. So also I have talked with the Chevalier and we talked in detail because my main practice is also OAGB. So we have talked in detail about this, but the main issue is jejunum. When we completely bypass jejunum, yes, we face such a malnutrition. What is my, so we must, so in such a, just imagine a patient morbid obese, 50, 60 BMI, and this patient need longer BP limb like 150, Runway, we are talking about Runway 150. So then what can we do? We can do standard Runway with 50, 100, then we distalize. So what will happen? We have jejunum there. That 100, we didn't bypass 150, just we bypass 50 of jejunum and other BP limb is ileum. So sir, because you are someone who are make guidelines for us, maybe you think about this, and if you will be in Oxford, IBCR and IPSO, we will talk more about this. So how can we think? Because what I am asking, Runway is an excellent procedure, but progressively, if we see the graph is going down. So why I am talking about this, how we can save this procedure. I am not interested to hear after 1 decade, oh, we had bypass and like gastric bypass, like no, we're talking about duodenal switch and other procedures, BPD. So this is my concern due to this, and also I will talk about some post-op about this. So maybe we can talk.
Now you really raise a great topic, and the distalization also doesn't work in all patients, but let's say the so to say sugarman distalization, where you prolong the biliary limb, seems to be the most effective conversion if your proximal Runway gastric bypass is not efficient enough treating all the comorbidities. So yeah, but however, you should not forget measuring the common limb and document it.
Yeah.
So the procedure itself is not difficult, the distalization, yeah, but the side effects for the patient could be very dramatic, and especially if you don't have a proper nutritional counseling and follow-up.
Yeah. Sir, thank you, sir. Sir, regarding closing defects, you have mentioned, so definitely you close all the defects. So we are interested to hear from your side, which technique you prefer, pierced suture or this is interpreted sutures?
I started with a purse string suture, and I'm still doing it if there is not a lot of tension. Otherwise, I do simply a running stitch.
Standing stretch. And what about hiatal hernia? Patient you diagnose before surgery, patient has till which, so it is necessary to repair, and which size you repair?
It's a great topic. If a patient really has a hiatal hernia, I'm not talking about 2-3 centimeter, because that we all have.
Yeah.
It's physiologic. But when you do your laparoscopy and you see this hole, then of course you close the defect and do a classic Runway gastric bypass.
Sure, sir. Sir,
in addition, what I also do is I fix the pouch to the left crus. That is what I have to address also. It's like a fundopexy, what we usually do in our paraesophageal hernias.
Excellent, excellent, sir. Sir, so now we will talk a little about post-op related questions. So we have still more and more questions due to shortage of time. We will go ahead. Sir, according to your protocol, post-op endoscopy, that surveillance, how you deal your patients?
Post-operative endoscopy, I don't do routinely. As long as a patient doesn't have symptoms and as long as a patient didn't have Helicobacter. So that I have to address asymptomatic patients. I don't. In the follow-up, it sounds a little bit strange, but I see my patients. And even gastric bypass patients, I see at least 2-3 years after the procedure. All my patients are connected with my digital. So that is super helpful. You know exactly of how all of your patients are doing. And I do simply a fluoroscopy to see, is there a pouch enlargement, yes or no? And interestingly, I have more than 1,000 x-rays that show there is no pouch enlargement, even in patients that suffer from 8 to 10% weight gaining. They all develop, let's say, a small bowel that adopts more food. And that is basically what you can demonstrate the patient. And it's not extremely difficult to treat in case a patient needs help. But the nutritionist will see the patient once a year. That is what I really make mandatory and obligatory. The practitioner with whom I work together will see the patients every year, doing laboratory tests. And what we get in Austria, we are very privileged because practitioner don't need to do it for free. They get from the insurance, so to say, a health check fee. And that is simply blood pressure, blood test, and the patient sends me the blood test. I have a big database on blood tests of my patients, and it's very rare that ladies are suffering from iron deficiency if, let's say, they overlook or oversee 1-2 years of follow-ups with their practitioners. Then it can be that they have iron deficiencies or blood deficiency because of not going to the follow-up.
Sir, excellent, excellent, sir. Sir, regarding H. pylori, if your patient is positive before surgery and you have eradicated, so in follow-up, is it necessary to check after 1 year after surgery, such a case H. pylori, or no, not necessary?
No. There are also no data about that, but I name it as a philosophy. If a patient is negative, so the stomach has no H. pylori, that's fine. You will not most probably have any problem. If a patient is H. pylori positive and doesn't have any ulcer or in the biopsies any dysplasia, I would say as long as in a gastric bypass no food is coming anymore in the
remnant,
let's say remnant stomach, my philosophy is there should not be a cancer development. but anyway, cancer is extremely rare in Europeans having gastric bypass. You're more likely die of heart attack or of stroke, not treating the disease, than having any of those side effects.
Yeah, sir, excellent, sir. So I am talking with someone who is, in my opinion, was a longer follow-up of Runway gastric bypass. Which percentage of your patients are suffering with marginal ulcer? Have you any data?
Yes, I had marginal ulcer. Is really a topic when your pouch is bigger and you have smokers. That is basically my marginal ulcer patient. The interesting thing is that the more you inform the patients, it would be great within the 6 to 8 weeks of preparation time. You also prepare yourself in not smoking, because the patients who had a marginal ulcer was taking severe anti-inflammatory drug. Patient was suffering from arthritis, immune arthritis, got immune suppressions. So in addition to NSAIDs, heavy smoker, I cannot remember that I had a marginal ulcer in a non-smoker, medication patients. Of course, it can happen, absolutely. But what I did was usually in stop smoking and even in resecting the ulcer.
Yeah, excellent. Sir, regarding this prevention of marginal ulcer, are you prefer PPI after surgery, and how long time you prefer?
Yeah, 4 to 6 weeks PPI is from the surgery.
It's sufficient. Sir, during this course now more than 2 decades, have you faced any intractable marginal ulcer, no response to conservative therapy, and need surgical intervention, and what you did for that case?
I did one case reverse to normal anatomy, and 2 cases where I resected the part of the stomach and the part of the small bowel where the ulcer was. I had no explanation why this worked, but these patients got routinely sacral fade. So that is topic sacral fade, sucralfate, as a routine treatment. It's a mucoprotective drug. Because my theory is that when you do your gastric bypass surgery, you really affect the mucoprotection. The mucoprotection that avoid our stomach getting ulcer. And in some patients you affect it. So you give, in addition from your medication, this mucoprotection.
Sir, excellent. Sir, nowadays, so definitely the role of endoscopic surgery is, we know all about this. Are you think it will be helpful in such a case when there is intractable marginal ulcer? Maybe with endoscope, we can, we can just, not it is debridement, just you can curate that ulcer side and maybe you stitch again that mucosa and cover that area. I have no idea. Are you agree?
Let's say it's a hypothesis. If you have this hypothesis, make a study out of it.
Then we can talk about this. Okay, sir, regarding weight regain, that is the main issue after Runway, because overall Runway definitely we have hypoabsorption in Runway, but overall Runway is restrictive procedure. The standard Runway that I am talking about 50-100. So which percentage of your cases are suffering with weight regain?
Okay. If you analyze your patients, you have around 1/3 of patients that will not achieve the weight that they had in their intention. That means at least 20% of body weight loss. So if you look on those patients who do not reach 20%, and you compare that to sleeve resection patients in your history, where you see studies where our colleagues really publish the semi-quantitative analysis, you will have much more patients in a sleeve resection that do not even achieve 20% compared to gastric bypass. But then there are much more patients that achieve 15%, 18%, and that is what I can say. 2/3 of patients will achieve more than 2/3 of their excess
body weight. Sir, sometime you do surgery, same standard, same technique for about same patients, not BMI same, but one patient achieve target, about 80% lose excess body weight.
Yeah.
Some of patients, they stop to lose. In such a situation, are you prefer to use GLP-1 derivatives?
Yeah, absolutely. That nowadays the GLP-2 are very, very effective if you combine that. But we know that we have a very multifactorial problem to treat, and there are also genetic factors that we should not forget on that. And basically, at the moment, we do experiment in those patients who, let's say, regain weight. But very effective is GLP-2. You have to give it only once a week. And in addition with our, let's say, also psychologists, because it is also a matter of expectations and other factors like sleep deprivation, like stress, family problems. You have so many situations, age, hormonal, etc., where you cannot achieve the honeymoon results.
Yeah, sir. Now, in your practice and your experience, how many cases you revise due to weight gain after Runway gastric bypass?
My own patients is very limited. It's less than 4 or 5% on this really long term. But here in my practice, I receive patients that have this problem of malnutrition, because they in Middle East the one anastomosis gastric bypass is very popular, and sometimes when I go in and measure those, they have biliary limbs of close to 3 meters sometimes excluded. So that is difficult to say, but my own patients where I did a study when I was head of a department 15 years, I had a rate of 4% of 1,400 gastric bypasses, but that was in between 2000 and 2015.
Sir, what you did in these cases? Are you distalize only, or resize the pouch, or different?
No, I put a band in those.
Band. Only additional band that was effective?
That was effective. It was an additional adjustable gastric band. It was an adjustable gastric band. In some of them, yes, they had an enlargement of the small bowel really tremendously. That I did resect or plicate, but in addition, they always got adjustable gastric band.
Sir,
Also patients with suffering from hypoglycemia.
Yeah, that is due to nizidoblastosis or dumping.
Dumping, yeah.
Due to dumping. Sir, why I am asking this? Because we have definite at this, we will be thousands of viewers that most of them are bariatric surgeons all over the world, and they are they will follow our this interview system. Why I'm asking this question? This adjustable gastric, how long time you are using this for weight regain after, and what was the result, and how many you removed due to any complication of this gastric adjustable band?
So I even had the privilege to publish that because we had people who studied very, very meticulously. And I did 20 courses a year on that. So all the participants could see how we do the follow-up, how we collect the data. And the revision rate was extremely low. It was it was close to 6% for complications like slippage. But I have to admit that my operating technique was different. I never did gastrogastric sutures, only fundopexy sutures. Slippage was extremely low. Erosion, well, I had experiences in all this kind of complications, but I never lost the patients for that. And I had let's say, to remove bands because of I am not happy, yes, in around 30%.
30% remove. Sir, what is your opinion about phobia ring in such a case?
I'm very, let's say, cautious on the phobia ring because I revised so many VBGs. Really, there were more than 300 VBGs that I had to revise. And the vertical banded gastroplasty had a band size of 6.5 centimeter. So if you use a wider band, I'm sure that it really has a good potential to reinforce your pouch. The data, what we have in literature, look really promising. Personally, I had a prospective study done in super obese patients with one anastomosis gastric bypass banded. And I had to revise 30% of that because they couldn't tolerate the restriction and the size was 7 centimeter of the non-adjustable ring. So from my side, I'm more the one who wants to have adjustable rings. I have such a great experience with the treatment of adjustable rings. I have the facility where I do it on the fluoroscopy, very, where I never over adjust the band, but also not under adjust. I see exactly when you have your fluoroscopy, your X-ray, you see the esophagus must clear. So a clearance of the esophagus is necessary, but also a building of a pouch above the band. So therefore, you can perfectly adjust the band only under X-ray. And that's the reason why it is not very popular anymore, because there are no surgeons doing that. And radiologists, they will not agree doing that. So that's the reason why, let's say, the adjustable ring, which is really a good device, especially in those who wants to have a surgery, but they don't have a high enough body mass index. So you will offer them a treatment which is extremely low invasive, very sufficient for those patients. And that is basically also what I do with those patients who gain 10, 15% weight after bypass, because that you can keep really good under control. If a patient is coming with a Runway gastric bypass and say, now I have the same weight as before, you have to consider a complete different procedure.
Sir, excellent. Sir, as we earlier discussed about longer BP limb and also side effects like malnutrition, but in some cases when BMI is high and there is more super obese patients, we need longer BP limb for better results. So are you think about this? So no need to increase BP limb you do get standard Runway, but with adjustable gastric band initially.
I think I mentioned it at the beginning that in super obese patients, I don't consider Runway gastric bypass. It is not comfortable to operate, ergonomic, not nice. For the patients, more risky. In those, I will consider one anastomosis gastric bypass.
Sir, this is also in the bracket. Are you happy with one anastomosis?
Yeah, I do one anastomosis, especially those who have a higher BMI of 50 above, and also patients who are on a higher risk, because you are quite fast with one anastomosis gastric bypass. You have only one anastomosis, and you can also reverse in case of need, but it is very, very efficient. It is, let's say, more efficient to weight loss than to a Runway gastric bypass, but also more side effects are.
Sir, what is your main concern about Runway gastric bypass now after this long journey of Runway? What is your main concern?
My biggest concern is internal hernia, even if you close the defects, because it's amazing what patients will lose on visceral fat. And even if you close the Peterson space, you might have the defect after significant weight loss. One patient who was also a member of the support group developed the internal hernia after 12 years, having had meanwhile 2 boys. So she had 2 pregnancies, quite a long time without any problem. And she called me last year and said, just for your record, I was operated with an internal hernia. But that, can you imagine, such a long time? I'm concerned about internal hernia. That is the only complication that I would be concerned if a patient is not going to the right hospital.
I understand. Sir, how you predict the future of Runway? As you have mentioned, now you have started one anastomosis. Professor Bruno also started one anastomosis, and many others, because now they are so following one anastomosis, and because overall we are scientists, we are realistic, we love our patients. How you predict the future of Runway gastric bypass?
It has a future, because my one anastomosis gastric bypass I had to reverse to Runway because of intractable biliary, or let's say this unpleasant pancreatobiliary reflux. That is something which you have more likely in countries where insurances are paying for that, compared to countries where they have to pay on their own. So that is also a selection of patients who will say, I suffer with this bitter reflux because I don't have the amount of money to pay to reverse. While in Austria, I'm, let's say, reluctant to one anastomosis gastric bypass because I had to reverse several patients back to Runway.
Sir, so much thanks, and really it was one of my best session, and personally definite. I learned a lot, because now I am talking with someone who has more than 2 decades experience of Runway. Sir, your message for our youngsters who are just now going to start bariatric surgery?
Okay, to start with is definitely to learn from experts. Don't believe everything what surgeons are telling you. Look at least to 2, 3 different surgeons. Don't learn only from one surgeon. And of course, you will start with sleeve resection. When it comes to bypass, what I did with my colleagues, I always let them do first the anterior anastomosis, parts of the procedure, like closure of the mesentery defect or dissecting of the pouch. You will not prolong the procedure, but you will get the expertise. To jump immediately on a bypass procedure needs, let's say, a lot of courage. You should start getting familiar with the patients, with the conversation to the patients, the follow-up clinic, and to do a gastric sleeve resection first. That is my recommendation, but in addition, also focus on anti-reflux surgery or centers who are doing reflux surgeries, because that is a topic which is a topic on its own, where you will be confronted sooner or later with patients who have reflux.
Sir, really so much thanks, and really so much. Always you are sportive and encouraging. Definitely we need your support, and in coming series also we need your support. And special thanks my viewers. Due to your support, always we can schedule such academic activity. If you have any question, you can ask in comments or directly from myself, and Professor will answer this question. Next week, because we have this session every Tuesday, 10 p.m. Next week, we will be with Professor Luca from Italy. He's also well-known bariatric surgeon. And definitely, we will have same session and we will continue our interview series for Runway gastric bypass. Sir, again, so much thanks, and hope see you in Oxford or in Miami, in IFSO Miami, definite. And we will talk more about different topics and future planning.
Yeah, thank you, Dr. Imran Abbas. I will be in Oxford. That is on my schedule. It's in September, yeah. And I will be not in Miami. It's not possible. I'm too busy at that time. But I will be at the IFSO meeting in Maastricht. I will be at the IFSO meeting in Khobar in Saudi Arabia. So don't hesitate. Contact me. I would love to share by a cup of coffee with you colleagues.
Thank you, sir. So much thanks. Have a nice time, sir.
Thank you. Bye. It was a great pleasure for my side.
Thank you so much. Thank you.